Just give me a minute. Yeah. Is it visible now?
Yes,
Yes,
and
yes.
we are live now. You can start.
Just give me a minute.
Okay, so
Perfect.
yes. Okay, so hello friends. Welcome to this edition of Innovations in Hematology. This is a brand new series which is based on the question and answers. We always heard the speakers and the specialists and the subject experts into their various fields. Today we have some questions. We have curated some questions for them. And as the new therapies are challenging our shows, it will be great enough to learn from the masters of this field in myeloma that how to navigate the new challenges. It is also a time to introduce that Fortis Institute of Blood Disorder has developed a state-of-the-art team with the first time being focused on single disease specialty, with Dr. Nikhil spearheading our lymphoma and myeloma specialty, along with Dr. Chitresh doing AML and ALLs, acute leukemias, and Dr. Anusha looking at the myeloproliferative neoplasms, the aplastics, the HLH, and so on and so forth. We have also have an addition of infectious disease specialists, which is helping us in developing the registries for CAR T cells and BiTE therapies, along with a geneticist who's from MD Pediatrics and DM AIMS in genetics, helping us to sort out the problems in hematology, along with a geriatrician who has done his MD from AIMS, again finding out the MGUS in these vulnerable population. So over to Dr. Nikhil, and it's a great pleasure that Dr. Shaji Kumar has graciously accepted our invitation on a very short notice. But next 30 minutes will be pleasurable for all of you, how he navigates his therapy areas to prolong the life, and ultimately, as Vincent says about operational cure in next, operational cure means people living for 10 years plus in all cytogenetic abnormalities. So over to Dr. Nikhil, who has done a remarkable job in streamlining our myeloma therapy areas, spearheading our teclistamab and telcitamab trials, along with the first CAR T cell from origin. So over to Dr. Nikhil.
Thank you, Dr. Bhargav. And it's a wonderful opportunity. And I would really thank Dr. Shaji for accepting our invitation at such short notice and allowing to chair this session. So today's session would be on sequencing therapies in triple class refractory myeloma. These patients pose a clinical challenge in our day-to-day practice, and very often we are faced with these patients who have exhausted most of the first-line therapies, undergone an autologous transplant, and also gotten treatments like daratumumab. So choosing a treatment for these patients is a challenge in a day-to-day clinical practice. And today, Dr. Shaji would enlighten us about sequencing BiTE and CAR T cell therapy in triple class refractory myeloma patients. Dr. Shaji Kumar needs no introduction. He's well known to all of us and a pioneer in the field of hematology and myeloma in specific. He's a professor of medicine at Mayo Clinic College of Medicine, consultant, Division of Hematology, and medical director at the Cancer Clinical Research Office at the Mayo Clinic, Rochester, USA. He heads the myeloma, amyloidosis, and dysproteinemia group at the Mayo Clinic and serves as a medical director for the Mayo Clinic Cancer Center Research Office and associate chair for research in the Department of Medicine. His clinical research focuses on outcome of patients with myeloma and amyloidosis and development of novel drugs for the treatment of myeloma. Dr. Shaji Kumar has led numerous landmark trials in the field of multiple myeloma and is on the editorial advisory board of many reputed journals. Before we go ahead with today's session, I would just like to inform our listeners that our upcoming webinar in the month of May would also be on a very pertinent clinical question regarding the optimal use of azacitidine venetoclax in AML patients in the Indian scenario. Dr. Jayastu Senapati, who is an associate professor in the Department of Leukemia, MD Anderson Cancer Center, would be giving this talk on the 17th of May. So to start with today's session, over to you, Dr. Shaji. He would be giving us a talk on sequencing, BITE, and CAR T cell therapy in triple class refractory myeloma patients. Dr. Shaji, you can share your screen.
Thank you. Thanks, Nico, for the introduction, and thank you, Rahul, for the opportunity. It's really refreshing to see all these new therapies becoming accessible in the Indian scenario. And let me see, is that visible?
Yes, your slide is visible.
All right. So, this is an area that is, obviously rapidly changing because these immunotherapies haven't been around for long, and we are still trying to better understand where do we use it specifically and how do we use it and how do we sequence it in particular. So I think one of the major advances that have happened in myeloma in the past few years during the past decade has been the introduction of a variety of different immunotherapies. And we are all very familiar with the anti-CD38 monoclonal antibody that has really changed the face of myeloma therapy. The antibody drug conjugates are still in development, and obviously we'll be seeing more of that. But today's presentation is going to be mostly focused on two specific types of immunotherapy. One, the bispecific antibodies, 3 of which are currently approved in the United States for clinical use, and chimeric antigen receptor T cell therapy, or CAR T cells, 2 of which are approved currently, which includes the ide-cel and the cilta-cel. Now, we had to really think about any therapy that we use in myeloma has to be thought about in the context of where do we use them. Now, obviously, there are a lot of preventive strategies which are currently evolving, which might use one or more of these immunotherapies. We are starting to see clinical trials that are utilizing many of these immunotherapies, particularly the CAR T and bispecific in the newly diagnosed setting. The anti-CD38 monoclonal antibody is firmly now become a part of that initial therapy of newly diagnosed myeloma, whether you are transplant eligible or not. Now, the early relapse, unfortunately, most patients with newly diagnosed disease, despite these effective therapies, would relapse. And the early relapse therapy is primarily focused on using triplet regimens, including those containing immunomodulatory drugs, proteasome inhibitors, as well as monoclonal antibodies. Where it becomes really challenging have been the late relapses, where clearly the effective, so many of the effective therapies, including the drug classes we just talked about, are no longer effective against the disease. And that's where we have seen these new immunotherapeutic approaches really make a difference for patients with multiple myeloma. So when you think about those patients who are already into their 4th relapse, most of those patients have seen the immunomodulatory drugs, the proteasome inhibitors, and anti-CD38 monoclonal antibodies, and are refractory to these 3 classes of drugs. And these are the patients we often refer to as the triple class refractory patients. Now, obviously, the underlying baseline cytogenetic abnormalities play an important role or determine how fast a patient becomes triple class refractory, with those with high-risk cytogenetics getting to be triple class refractory much sooner. But even more relevant is the fact that once you get to be triple class refractory, your outcomes are relatively poor, and especially if you don't respond to the subsequent therapy, then you're talking about median survival less than a year. So that's where the new therapies have entered the scene. And obviously, the very first one to be approved was the CAR T cell, the Captigene viclocelular ide-cel. And again, just to refresh everyone's memory, the CAR T cells are all designed in a way that the T cell receptor has been modified in order to recognize a specific antigen, which is BCMA in case of ide-cel and cilta-cel. Now, BCMA, or B cell maturation antigen, is something that is fairly unique to the mature B cells and the plasma cells with very little expression elsewhere. So forms an ideal target for treatment for myeloma. They all have an intracellular co-stimulatory domain and a T cell activation domain. And these T cell receptor structure continues to evolve rapidly with a variety of different modifications and enhancements, which will make the CAR T cells more effective in the future. Now, with ide-cel, there was the very first study that was the KARMA study, that looked at the ide-cel in patients with advanced relapsed refractory disease and demonstrated that at the recommended dose of 450 million cells, we get an overall response rate of almost 80%. And more importantly, a significant proportion of these patients were MRD negative, something that we previously would not have seen with most of the therapies in this late stage of the disease. Of course, it does come with some cytotoxicities, some toxicities that we'll talk about in a little bit. But primarily, what we are always thinking about with these CAR T-cell therapy are the cytokine release syndrome and neurotoxicity. Now, similarly, we had the CARTITUDE-1 trial showing that cilta-cel, which again is a very similar BCMA targeting bispecific targeting CAR T-cell, but with 2 binding domains instead of 1 binding domain. And you can see that the response rate is close to 100% of these patients actually respond to therapy, and including almost a 95% of the patients in a very good partial response or better. So very high degree of efficacy. And when you look at the durability of the response, you can see that the median PFS for the overall patient population is maybe closer to 3 years plus. And if you get a good response, or you get into a complete response, then your median PFS is exceeding 3 years. And the median overall survival is far exceeds what we would have expected in this particular patient group if they had not received this particular therapy. Now, obviously, there are a lot of new CAR T cells that are currently going through development. So I won't go into the details of all these, but clearly many of them are targeting BCMA. And that is, again, a validated target. Some of them are looking at different approaches for manufacturing that can be much quicker. And that will allow us to get these treatments to the patients sooner. But we also have CAR T cells that are being developed against alternate targets, for example, the GPRC5D. And you can see that there's many of them that are going through clinical trials right now. And there is also the concept of dual targeting we'll come to in a little bit. Again, with the hypothesis that if you target 2 different antigens, then you are able to get a more lasting response in these patients. Now, the other class of T-cell directed therapy is the bispecific T-cell engagers. It's a pretty simplistic approach. It's basically a monoclonal antibody, but with 2 different specificities. The one of the binding domains recognizes CD3 on the T-cell, and the other recognizes a tumor antigen of interest on the tumor cell, BCMA being the most common in the myeloma setting. And you can see that it essentially brings the T cells, the immune cell, and the target cell close to each other, resulting in the formation of a cytolytic synapse and tumor cell death. Now, we have several bispecific antibodies that are going through trials and some approved. Teclistamab was the very first one to be approved. And as you can see here in a patient population that is relatively similar to what was included in the CAR T trials, a overall response rate is about 60%. And the median PFS was about a year. So very similar when you think about the ide-cel data in terms of median PFS, even though the responses are maybe a little less in terms of in the bispecific antibodies. But again, you have to also keep in mind that bispecific antibodies are given continuously compared to the CAR T cells where it's given once and then no further therapy. Now, elranatamab is another BCMA-targeted bispecific antibody. Again, you can see that the overall response rate is about 60%, very similar to teclistamab. There are some differences between the two, especially in terms of the frequency of administration and so forth. And then when you get a good response, you can see that the median progression-free survival or the durability of response is pretty good. Of course, you don't get that when you're talking about patients who, don't get a good response. So the overall median progression-free survival here is maybe closer to like the 15, 16 months. But again, we will continue to get more data from the ongoing clinical trials. Now, talquetamab was the first bispecific antibody that was approved in patients that used a different target. In this case, it's the GPRC5D. And again, when you look at the results of the initial trial looking at talquetamab, you can see that the overall response rate, especially when you look at the 800 milligram every 2 weeks, it's about 60%. or if you look at the slightly higher doses, then you can see that maybe a slightly higher response rate as well. So what about bispecifics? Just as we saw with the CAR T cells, we have a variety of different bispecifics and now even trispecifics that are going through clinical trials. Obviously, the goal, many of them are targeted towards BCMA, but there are others that are looking at alternate targets, including the GPRC5D like the talquetamab and also FCRH5, which is the target of cevostamab that is going through clinical trials as well. So the questions that come up, especially with respect to the practical utilization of these therapies, and again, we don't have answers to all these questions, but hopefully as the data comes in over the next few years, we'll get a better sense of how we can answer these questions, which has significant implications on how we're going to use it in the clinic. So, question, where should we use the therapy? Should we be using in relapse? Should we be using in newly diagnosed patients? Which one should be used first, CAR T or bispecifics? And if you're going to use two of these therapies, should they have different targets? Should there be a different gap between the two sequential therapies? Can we combine them either concurrently or sequentially? And what does the toxicity profile tell you in terms of what sequencing you may want to use in a given patient in front of you? So one of the biggest questions is, when should we actually do the CAR T cell therapy in order to, or T cell directed therapy in order to obtain the maximum benefit? Now, obviously, we all know that patients go through multiple different therapies. Their T cell functionality continue to decline. And this is some preclinical work that have been done showing that in patients who have previously been exposed to these T cell directed therapies, their lymphocytes are probably, or T cells are less functional, using a variety of different assays that have been used. So the question is, yes, so clearly there's some advantage in trying to use these therapies early on in the course of the disease before they have seen a lot of different therapies and the T cell functioning has diminished. So the KarMMa-3 trial looked at, it's a randomized phase 3 trial comparing ide-cel versus standard of care therapies in patients who have had 2 to 4 prior lines of therapy, and demonstrated that there was a significant improvement in the PFS, and recently led to the change in the label by the FDA to include patients with 2 to 4 prior lines of therapy and who have been exposed to all 3 classes of drugs. Similarly, the CARTITUDE-4 trial looked at cilta-cel versus standard of care therapy in patients who have received 1 to 3 prior lines of therapy who are lenalidomide refractory. And again, the trial showed that there was a significant improvement in the PFS with the cilta-cel compared to standard of care therapy. So clearly using the cilta-cel in the early lines of therapy is practical and seem to be better than some of the contemporary regimens that we use, but still leaves some questions unanswered. One is, of course, with many of these therapies, the control arm did not include the most effective triplets we have, like the anti-CD38 carfilzomib combinations, Dara-KD or the isatuximab-KD. The second thing is, on the right-hand side, you can see the outcomes in patients with the CARTITUDE-1 who had more or 3 prior lines of therapy, and CARTITUDE-4 with 1 to 3 prior lines of therapy. You can see that the progression-free survival is quite comparable, suggesting that, raising the question, is there a lot of benefit in using the CAR T cell much ahead in time? Unclear. But again, it's you also have to keep in mind the fact that the cilta-cel was a one-time therapy here, whereas if you had used a standard of care therapy, that would have continued for a long period of time. So what happens when you are using this CAR T cells after other BCMA-targeted therapy? And this is some of the real-world evidence showing that if you have prior BCMA-targeted therapy, then clearly your progression-free survival is inferior to the people who have never seen BCMA-targeted therapy. Of course, these are observational studies, and clearly there could be bias in terms of what kind of patients are being looked at, who have previously not received BCMA therapy versus who have. And when you look at the overall survival, maybe there is some suggestion that if you received BCMA, again, the same thing, that if you have not received BCMA therapy, then your outcomes are better. What about using cilta-cel after prior BCMA-targeted therapy? You see the same thing when you can see that you do get responses. You do get some durability of response. The median duration of response was only 11 months, which is almost a third of what we would have seen in the CARTITUDE-1 trial, suggesting that prior exposure, whether it be antibody drug conjugate or bispecific antibodies, your response to the cilta-cel do go down. But what happens when you use therapies after the patients relapse from CAR-T, right? So if you look at the different groups here, you can see that patients who relapse after prior CAR-T cell therapy, and if you salvage them with a bispecific antibody or another CAR-T cell, you still seem to get a decent responses and decent durability of response. So clearly, it doesn't, using one T-cell directed therapy after another one still is associated with good response and good durability of response, but less than what you would have anticipated if they had never seen a T-cell directed therapy. So what about the other way around? What if you are looking at the bispecific antibodies and what are the responses if they have previously seen CAR T-cell therapy or ADC? And here's the teclistamab data. You can see that in the patients with prior CAR-T, the overall response rate is about 57%. It's a little less than, or fairly comparable to, again, different patient populations. And if you had seen a prior ADC, it's about 50%. Now, again, here you can see that in patients who have received a ide-cel therapy before, you can see that the teclistamab activity is substantially reduced. It's about 30%, and the PFS is also significantly lower in patients who have previously seen ide-cel before getting the teclistamab. What about elranatamab? Again, you can see here that people who have had prior anti-BCMA therapy, the response rate is about 46%. And keep in mind, this was about 63% on the overall patient population in the LRAN study. So how do we get around this? Can we use a different target? Can we use multiple targets in order to overcome the problem? We can look at the data from the GPRC5D targeting CAR T-cell therapy. And you can see that patients with a prior BCMA targeted therapy, you do see a reduce in the response rate from the 96 in those who did not to about 76 in those did. So even when you're using a different target, you still are losing some efficacy, and that may be a reflection of the T-cell function in these patients. In the Monumental 1 trial, if you look at the patients who had previously seen a prior T-cell redirection therapy, you can see that the overall response rate do go down, particularly in that subgroup who had previously seen bispecific antibodies. And if you look at it again across the cohorts, you can see that the median duration of response and the median PFS is also significantly lower in patients who have previously seen T-cell redirection therapy, 5.1 months versus about 14 months in those others. The other option is to use combinations, right? So we can use talquetamab in combination with daratumumab. We can use teclistamab in combination with daratumumab. And in the TRIM2 trial, we can clearly see that even in patients who have previously been exposed to T-cell redirection therapy, you can still get good responses by using these combination approaches. And another approach is to use two different antigens to be targeted at the same time. So this is the GC012F from the Gressel Therapeutics that has been studied even in newly diagnosed disease. But overall, it clearly seems that the dual targeted CAR T cells very effective, high overall response rate, very good duration of response, and very fast onset of response as well. Now, we don't know how they compare head-to-head with a BCMA alone targeted CAR T cell. Those kind of trials have not been done yet, but it's certainly an intriguing hypothesis that will have to be explored as we go ahead. Now, the another aspect that is under exploration is the use of allogeneic CAR T cells. Advantage of allogeneic CAR T cell obviously is off the shelf. You can give it to the patients right away. However, certainly have some disadvantages in the sense, these patients need more profound immunosuppression. It does definitely need some more tweaking of these T cells in order to avoid the any kind of graft versus host disease. So there are clearly there's a pros and cons for autologous versus allogeneic CAR T cells. Won't go into a lot of the details, but again, I think the advantage is the earlier use of therapy. However, the data with the allogeneic CAR T cells so far has not really shown any advantage over the autologous CAR T cells. So obviously, I think there's still much that needs to be learned. Now, obviously, the management, the toxicity management across both the bispecifics and the CAR T cells has some common things. The cytokine release syndrome is common across both groups, even though the cytokine release syndrome tend to be of a less severe grade in the in the bispecific antibody population. The neurological toxicity is again less severe and less frequent in the bispecifics compared to the CAR T cells. You can rarely skip patients with HLH or the macrophage activation syndrome that can sometimes be fatal. So it's can sometimes be hard to treat. There are some long-term toxicities that we see in these patients, including prolonged cytopenias and T cell suppression may be related to the use of fludarabine, B cell aplasia leading to hypogammaglobulinemia, and also significantly elevated risk of infections in some of these patients. So there are a lot of different adverse events, and if you look across these different trials, looking at a variety of different bispecific antibodies and CAR T cells, you do see that there is significant cytopenias that you can see, increased risk of infections, certain toxicities like dysgeusia is uniquely seen in patients getting GPRC5D targeted therapy, same for the skin rash and nail-related events. But the cytokine release syndrome and neurotoxicity are the more common toxicities. And I think we are continuing to learn how best to take care of patients with these toxicities. And then, in terms of, what you might use first can to some extent may also depend on what the patient is able to tolerate. So if you have disease that is rapidly progressing, then CAR T cell may not be the appropriate thing. A bispecific antibody may be the first thing that you may want to use. If it is a more old, more frail patients, maybe there's advantage to using the bispecifics first. And again, if they have good organ function, they're able to get good through the CAR T cell therapy. Our preference is to use the CAR T cell before the bispecific antibody. And sometimes, the logistics, patient preference, and all these things would also play an important role in deciding which path you particularly take in a given patient. So I think both just to conclude, both T cell directed therapies, whether CAR T and bispecific, they are both effective treatments. And there is no convincing evidence that using them in the newly diagnosed setting would have an advantage of using it in the later lines so far. But I think those are the clinical trials that are ongoing right now. The response rates will continue to drop once you use one T cell redirection therapy after the other. How do we get over this limitation? Can we possibly by using a different antigen targeted or using dual antigen targeting, or giving some adequate gap between these different therapies, or using different approaches to enhance the function and the durability of the T cells. So I think these are all different approaches that are being explored in order to maximize the benefit of the T cell reduction therapy. And of course, at the end of the day, reimbursement, ability to tolerate, and logistics will also play an important role. So with that, I'll stop and be happy to take any questions.
Thank you, Dr. Shaji, for that excellent lecture. You covered all the recent advances and all the possible treatment options in the pipeline for this difficult set of patients. It was wonderful listening to you, and our audience from 10 different countries and over 200 doctors all across the globe are listening to you at this point. I would like to go on with the question and answer session. We have collated few questions that have received from our Indian colleagues. So can we go ahead? Dr. Shaji, are you able to hear me?
Yep, I can hear you fine. Yes, go ahead.
Is there any specified duration of exposure to each class of drug before we label them refractory?
So in general, for the clinical trial purposes, refractoriness is defined as progression on treatment or within 60 days of discontinuing a particular therapy. And the refractoriness is often defined in terms of what particular agent that the patient is refractory to. Now, it's kind of a little harder in the context of CAR T cells. how do we define them as refractory? Because obviously that's not a continuous therapy. So eventually, as we get more experience, we'll probably define them on the basis of how long the response lasted in the absence of a maintenance therapy, but to say if they are relatively refractory to a CAR T-cell approach.
The next question is, are there any baseline predictors for like high-risk cytogenetics or mutations that can predict a refractory disease? A possibility of the patient becoming refractory to initial line of treatment.
Right. So eventually all patients will become refractory to all the therapies we apply, but there are certain characteristics at baseline that predicts that someone is going to become refractory to multiple drugs in in a short time frame, and that's predominantly high-risk cytogenetics. So in the era of quadruplet therapy, it's unusual to see primary refractoriness to the initial line of therapy, but that still happens. So those patients have often very poor prognosis. The next comes the patients we often refer to as functional high risk, and these are patients who relapse within the first 18 months or so, and they also tend to have poor outcome. And then the rest of the patients will eventually become triple class refractory over a period of time.
Next question is related to that. If patients have received daratumumab and they have been dara unexposed for a significantly prolonged period, like 6 months to 1 year, can they still be re-exposed to dara considering that they had an initial response when they turned refractory to other treatments?
Yeah, absolutely. And I would frame it in the frame the answer in the context of general anti-CD38 monoclonal antibody, because we have two of them, daratumumab and isatuximab,
Right.
both of which appear to be equally effective. So, it's not just something unique for the anti-CD38. I think all myeloma drugs, we know we can reuse them as long as the patient has not seen it for a period of time. There is no defined period per se. It all depends. The longer the gap between the first and the subsequent use, the more benefit you're going to see with that drug. But invariably, when you use a drug the second time, the depth and the durability of response is going to be less than what we obtained in the very first time.
And when a patient becomes triple class refractory, should an NGS be done? Is there any role of NGS in a triple class refractory patients before deciding on further treatment?
So if you're thinking about in the context of using a CAR T-cell therapy or bispecific antibody, there's really not much from the NGS data that is going to inform you of whether to use a CAR T or bispecific or what to use. There is some data showing that mutations in the BCMA antigen can increase the resistance, or even the loss of BCMA can lead to resistance to the CAR T and bispecific antibodies. But I don't think we are at a point where we can use the data to decide on whether to use them or not. Where it can be useful is, especially maybe in the current setting, once they're even refractory to the T-cell redirection therapy, you see that a major clone has a mutation that you can target. For example, a RAS mutation. We know that we see that in almost half of these patients. Then treatment with a MEK inhibitor might be helpful, but often even in that case, a single agent MEK inhibitor is unlikely to give you durable deep responses. So you may want to think about using that in the context of in combination with other therapies.
If a patient progresses on BCMA CAR T, can they be offered a different GPRC5D CAR T cell therapy?
Absolutely. I mean,
If patient progresses on one CAR T cell therapy, later on, can they be offered a different CAR T cell focusing on a different
yeah, I
target?
think it certainly you can offer them, and we know from the data that it certainly can be effective as well. However, most of the time, it's from a finance standpoint and insurance standpoint, it is not something that is often or that's something easily available.
And going forward with CAR T cell coming in earlier in the lines of treatment of myeloma, do you see CAR T cell therapy at one point becoming potentially curative for myeloma patients if they are used early in treatment?
It's hypothetically, yes. There may be patients where you can get deep enough response that they are potentially cured with that initial first-line therapy. We do see a fraction of patients getting cured even with the current therapies. Probably is about 15%, but that's a number that's likely to keep going up with the new treatments.
Great. I think you already answered this in your talk, but what are the different BiTE therapies available and how do they compare with each other in terms of efficacy?
So again, I think we have to be careful of how we term it. BiTE is something, it's a proprietary name that is owned by Amgen. So bispecific antibody is probably a better way to refer to them because it's that encompasses all the different therapies we have. Yes, I think what we have seen is across all the bispecific antibodies, we certainly see a relatively similar response rate of about 60 to 65%, irrespective of the antigen being targeted. So I think um, it's really nothing much to choose between the different bispecific antibodies, the exception of maybe the toxicity profile. Obviously, if you target the GPRC5D, you do see skin and nail toxicity and altered taste, which can be quite cumbersome. If with some of the agents, they have been maybe a little more of cytokine release syndrome versus the others. Some are given weekly, whereas others are given every 3 to 4 weeks. So convenience could be a factor in terms of deciding which one to use.
And this question, I think, holds a lot of relevance in the Indian context. Both bispecific as well as CAR T cell therapy are still not freely available in our country. So, for triple class refractory myeloma patients, in the absence of these two, what are the other potential options that can be explored in an Indian setting?
Yeah, I think it's an important question. I think we have to think about, we have to take a very careful look at what they have received, how long ago did they receive it, and were they truly refractory. So if somebody is not truly refractory to a therapy, you can always reuse it. If they have not seen it for a long time, can still reuse it. And if they cannot use any of the three major classes, then the others that are available, like selinexor, it's a small molecule drug that has been approved, typically used in combination with the anti-CD38 or a proteasome inhibitor. Patients with 11-14 translocation, we have seen really good activity with venetoclax, often again used in combinations. And then there are older therapies, that have previously has been shown to be effective, right? So especially if it's an older patient who is unlikely that you're going to be thinking about an auto transplant or collecting cells for a CAR T, then melphalan-based therapy is very reasonable. But use of high dose alkylators, whether it be melphalan or whether it be bendamustine, you really have to be careful. If it's someone whom you think can go to CAR T later on, you should not use those. Otherwise, certainly those would be reasonable too.
One more question in the chat box. Does anti-BCMA therapy hold the risk of antigen escape and subsequent relapse?
Certainly, there are different mechanisms of action that are probably in place. The vast majority of the patients relapsing on a BCMA bispecific antibody still retains the expression of BCMA. So it's more likely that it's more of a T cell function that is the problem here. However, there is a proportion of patients where either the BCMA expression is still there, but the antigen is mutated, and the binding capacity for a given bispecific is no longer there. And those patients might respond to a different bispecific or CAR T that is targeted towards the BCMA. That can still bind the mutated BCMA. And there's a few where there's biallelic deletion that leads to the lack of BCMA expression completely, where of course there won't be any activity either.
Great. I think you covered this also in your talk, but what are the new treatment options in pipeline for these patients? Other than the CAR Ts and the bispecifics that we discussed about, are there any other potential agents which are in the pipeline for triple class refractory myeloma patients?
Yeah, so within the same class of the CAR T and the bispecifics, there are CAR Ts that are being that are continuing to be improved. One is obviously the manufacturing time, the manufacturing methodology instead of LND viral vector, different approaches. And then most importantly, trying to see if we can make the CAR T cells mount a more robust response by what we call the armoring the CAR T cells, or an armored CAR T cell where they might be also engineered to secrete cytokines to overall enhance the immune reaction that happens. There are also approaches to try and see if we can get more of the naive T cells into the mixture so that the durability of the T cells hang around for a longer period of time. And with bispecific antibodies, clearly there are approaches to try developing trispecific antibodies and also using different antibodies in combination and so forth. So a lot of exciting things in that immune arena that are looking at tweaking these two principles of therapy.
Great. And which one is superior, CAR T cell, CILTA versus ID cell?
There is no trial looking at them head to head, and it's difficult to compare the data from the uh, CAR-T2 trials to the KARMA trials because the patient population was different in the two studies. Now, the median PFS with the ide-cel that has also been confirmed in real-world studies in that late stage is about a year, or slightly less. With cilta-cel in a slightly different patient population, but still late stage was close to 3 years. So it's, there's obviously with more and more real-world studies coming out, we'll get a better sense.
Great. And another question is, in those patients who relapsed after CAR T cells, did they restore the BCMA expression? I mean, that's
Yeah,
not.
so some of them, again, remember that myeloma is a heterogeneous disease with various subclones. So when you look at the patient's myeloma, yes, we see the BCMA sometimes coming back. That's because the BCMA expressing clone now is growing back up. And it's possible that the BCMA non-expressing clone decreases in size as we stop therapy and the therapy selection pressure goes away.
Any role of tandem transplant in young patients compared to a single autologous transplant, especially in those patients who have not received it?
Yeah, I think, the European data would suggest that you can consider doing a tandem auto transplant in high-risk patient population. However, in our own practice where we have very effective um, injection therapy and a two-drug maintenance, then I don't think there's really a role for tandem auto transplant in that setting.
Can we do a CAR T cell as a consolidation in a young high-risk patient post autologous stem cell transplant?
Absolutely. I think that is being explored in clinical trials, and I think in particularly in this high-risk patient population, that may be important. Again, it's, the problem with the high risk is not that we don't get a deep enough response, it's the ability to keep them in response. So I think with our current level of knowledge, it's hard to visualize a setting where you don't need some kind of maintenance in this high risk patient population, but it is obviously something that needs to be studied.
Should there be any maintenance treatment after a CAR T cell therapy? Is
Now,
it warranted?
right now it isn't typically used, but some of the upfront trials that are looking at CAR-T, maintenance is included post CAR-T. I think, again, as I said, it's probably going to be much more important for those patients with high-risk disease that we use the maintenance.
What is the best treatment option available for relapsed patients with multiple extramedullary disease sites?
These patients are obviously high-risk disease. And many of those people, we tend to use VDT-based type regimens to try and debulk some of that extramedullary disease before we move them on to a more definitive therapy, whether it be transplant or CAR T cells or other immune-directed therapies. Because these are the patients who don't seem to do very well with the CAR T and the bispecific antibodies nowadays.
Going forward, how would you sequence treatment in a fit and eligible patient, auto transplant, bispecific, and CAR T cells?
Right now, I think based on the phase 3 trials, the auto transplant should be the part of the initial treatment, and the others come up at the time of relapse. But there are clinical trials like trying to see if we can replace the auto transplant with these newer therapies, particularly CAR T cells. So it to be determined.
And I think you already spoke about venetoclax in relapsed multiple myeloma for patients with translocation 11-14. Does CAR T cell work across all cytogenetics groups?
It appears that it's effective in all patients in terms of inducing the response, but obviously the high-risk cytogenetics patients tend to relapse faster.
Any data regarding the use of GCSF post-CAR T cell treatment? Early on in post-CAR T, does GCSF affect the proliferation of CAR T cells?
They don't affect the proliferation because, again, the GCSF is going after the myeloid lineage, especially the neutrophils. We don't typically use GCSF routinely. Only if patients have persistent cytopenias do we use GCSF.
And for an extramedullary disease, bispecific versus CAR-T, which would be preferable?
That's a hard question in the sense the data suggests that neither of them work as well in the extramedullary setting. So I think there's a room for us to try conventional therapies to debulk the disease before starting them on treatment. Having said that, I think if the CAR-T is available, I think prefer to use that over the bispecific for right now.
With different CAR-T cells hitting the market, how do we compare one CAR-T cell with other? In a clinical sense, how do we compare the efficacy and choose which CAR-T cell would be best for our patients?
Yeah, it's unlikely we'll have comparative trials between these, so I think we'll have to rely on the real-world evidence that is generated in terms of using one versus the other. And there may be situations where the toxicity profile might suggest that a specific one is used instead of another one.
And in patients with myeloma and associated amyloidosis, is CAR-T still equally efficacious?
Yes, I think there's a very limited data, mostly from the Israeli group, where they included a bunch of patients who had amyloid and myeloma and seemed like it can be effective. And we know in general, therapies that we use in myeloma are effective in amyloid as well in terms of getting rid of the clone. So we hope that it will also be helpful for those patient populations.
I think we have completed all the questions in the chat box. Once again, thank you, Dr. Shaji, for patiently answering so many questions and clearing all our queries. It was wonderful listening to you. I would thank you once again for giving such an elegant lecture in such a short span of time. You have covered the topic very well and made clinical practice a lot easier. And hopefully this would contribute to treatment of triple class myeloma patients better. Thank you so much.
Thank you.
Thank you,
Bye.
Shaji, and look forward to
Bye,
see you
Rahul.
more academic meetings and a collaboration for amyloidosis. Thank you, Shaji. Thanks a lot.
Yeah, take care. Bye.
Bye-bye. Thank you. Thanks a ton.
Mr. Nikhil, you are muted.
Sorry, once again, on behalf of Fortis Institute of Blood Disorders, we thank all the participants who have attended this webinar. We hope it was a useful learning experience and Dr. Shaji's talk would help us in making our clinical practice better. Thank you all, and we'll join in next month with the second webinar session on use of azacitidine and venetoclax in AML patients in the Indian setting, with a similar discussion with Dr. Jayastu from MD Anderson. Once again, thank you all.
And thank you, MCure, for a flawless conversation and the platform. Thank you.
Thank you very much, sir.
Thank you. We come to an end today. Thank you.